Welcome to my video on pulmonary vascular disease. We're going to talk today about pulmonary embolism and pulmonary hypertension. Information is courtesy of Clinical Manifestations and Assessment of Respiratory Disease by Terry Desjardins and George Burton. I highly recommend this book for any respiratory care student. First, we'll talk about pulmonary embolism. A blood clot that forms and remains in a vein is called a thrombus. A blood clot that becomes dislodged and travels to another part of the body is called an embolus or embolism. In some cases, when the embolus significantly disrupts pulmonary arterial blood flow, a pulmonary infarction may develop, which in turn may cause alveolar atelectasis, consolidation, and tissue necrosis. Bronchial smooth muscle contraction, occasionally accompanies pulmonary embolism, although the precise mechanism is not known. It's believed that the embolism causes a release of cellular mediators such as serotonin, histamine, and prostaglandins from platelets. These in turn lead to bronchoconstriction. Local areas of alveolar hypocapnia and hypoxemia may also contribute to bronchoconstriction associated with a pulmonary embolism. An embolus that originates from one large thrombus, or it can occur in a shower of little thrombi. It may or may not interfere with the right ventricle's ability to perfuse the lungs, and a large embolus that detaches from a thrombus and passes through the right side of the heart can lodge in the bifurcation of the pulmonary artery, where it forms what is known as a saddle embolus. A large saddle embolus is often quickly fatal because it can significantly block pulmonary blood flow from returning to the left ventricle and being pumped out to the systemic circulation. This is partially shown in a figure that we'll look at next. So, anatomic alterations of the lungs include blockage of the pulmonary vascular system, including pulmonary hypertension and cor pulmonale, pulmonary infarction, which means that pulmonary tissue is dying, alveolar atelectasis, alveolar consolidation, and bronchospasm. Common secondary anatomic alterations of the lungs include pulmonary emboli, smooth muscle constriction, atelectasis, and alveolar consolidation. And that PE that you saw, that was a saddle pulmonary emboli in the pulmonary vascular system. Let's talk about how this happened and who gets this. So deep vein thrombosis, or DVT, and pulmonary embolism are often clinically insidious disorders, which means they happen and you don't even realize it's happening. If the pulmonary embolus is relatively small, the early signs and symptoms of the embolus are often vague and nonspecific, By contrast, sudden death is often the first symptom in about a quarter of people who have a large pulmonary embolus. A massive pulmonary emboli is one of the most common causes of sudden and unexpected death in all age groups. Many cases of pulmonary emboli go undiagnosed and therefore untreated. In fact, because of the subtle and misleading clinical manifestations associated with pulmonary embolism, the possibility of a blood clot lodged in the lung is often not considered until autopsy in about 70 to 80% of cases. In the United States, about 100,000 individuals each year die from a PE. PE is more common in males than females, and the incidence increases with age. The experienced healthcare practitioner actively works to confirm a diagnosis of pulmonary embolism as soon as they are suspicious of it. This is especially true as the origin of the signs and symptoms of pulmonary embolic disease often cannot be readily identified. It's tough to diagnose this, folks. Although there are many possible sources of pulmonary emboli, fat, air, amniotic fluid, bone marrow, tumor fragments, blood clots are by far the most common. Most pulmonary blood clots originate or break away from sites of deep vein thrombosis in the lower part of the body, meaning the leg or pelvic veins, or the inferior vena cava. When a thrombosis or a piece of a thrombosis, a blood clot, breaks loose in a deep vein, the blood clot, now called an embolus, is carried away. Through the venous system to the right and ventricle of the heart and ultimately lodges in the pulmonary arteries or arterioles. There are three primary factors known as the Virchow triad associated with formation of DVT. The Virchow triad includes venous stasis, meaning slowing or stagnation of blood flow through the veins, hypercoagulopathy, the increased tendency of blood to form clots, and injury to the endothelial cells that line the vessels. If you have your book and you're looking at it, there's a great box on this that shows you risk factors associated with pulmonary embolism, and I highly suggest that you look at that. It's box 21.1. Diagnosis and screening. We're going to start with diagnosis. Diagnosis is based on the clinical manifestations that support the possibility of pulmonary embolism, followed by the results of a variety of possible blood tests, venous ultrasound, and one or more lung imaging techniques to secure a definitive diagnosis. Depending on how much of the lung is involved, the size of the embolism, and the overall health of the patient, the signs and symptoms of a pulmonary embolism can vary greatly. There may be sudden shortness of breath, cardiac arrhythmias, weak pulse, lightheadedness or fainting, anxiety, excessive sweating, or cyanosis. So this is a CTPA, or a computed tomography pulmonary angiogram. Intravenous contrast material is very, very bright in the visible portions of the superior vena cava in the superior portion of the right atrium, because the contrast material was injected into the antecubital vein. The contrast material mixes in the right atrium with the darker blood without contrast from the inferior vena cava, resulting in a moderate brightness in that chamber, the right ventricle, and the pulmonary artery. The relatively dark area, which is the thrombus, in the right pulmonary artery is clearly outlined against the brighter area, blood flow. CTPA is the best imaging procedure when pulmonary embolus is suspected. So on this side, this is a normal pulmonary artery. And so you can see that here's the right atrium. You can see that there's nothing there. Here, you can see clearly that there's a darker mass in that right atrium. Common tests for suspected pulmonary embolism include blood test, D-dimer blood test, ultrasonography, chest x-ray, CTPA that we just saw a picture of, ventilation perfusion scan, pulmonary angiography, MRI, and MRA. Clinical manifestations associated with pulmonary embolism. The following clinical manifestations result from the pathologic mechanisms caused or activated by the major anatomic alteration of the lungs associated with a pulmonary infarction. Bronchospasm may also explain some of the following findings. It occurs rarely and is of little clinical significance compared with atelectasis caused by pulmonary infarction and hypoxemia resulting from the increased physiologic dead space. Vital signs: increased respiratory rate, tachypnea, stimulation of the peripheral chemoreceptors, and reflexes from the aortic and carotid baroreceptors. Several unique mechanisms probably work simultaneously to increase the rate of breathing in patients with pulmonary embolism. There's increased physiologic or alveolar dead space. Pulmonary embolic disease is a classic example of this type of pathophysiology. For example, an embolus lodges in the pulmonary vascular system, blood flow is reduced or completely absent distal to the obstruction. Consequently, the alveolar ventilation beyond the obstruction is wasted or dead space ventilation, and no carbon dioxide-oxygen exchange occurs. The ventilation perfusion or VQ ratio distal to the pulmonary embolus is high and may even be infinite if there is no perfusion at all. Although portions of the lungs have a high VQ ratio at the onset of a pulmonary embolism, this condition is quickly reversed and a decrease of the VQ ratio occurs. The pathophysiologic mechanisms responsible for the decrease in VQ ratio are as follows. In some cases of pulmonary emboli, pulmonary infarction may develop and cause alveolar atelectasis, consolidations, and pulmonary parenchymal necrosis. In addition, embolus is thought to activate the release of humoral agents such as serotonin, histamine, and prostaglandins into the pulmonary circulation, causing bronchial constriction. This shows in an uncomplicated pulmonary embolism none of the clinical scenarios presented. In these patients, increased alveolar physiologic dead space, wasted ventilation, is the primary pathophysiologic mechanism. Emboli and no perfusion. Wasted ventilation. Venous admixture may develop in pulmonary embolism as a result of bronchial smooth muscle constriction or shunt-like effect. Venous admixture also may occur when an embolus leads to pulmonary infarction and causes alveolar atelectasis consolidation or true capillary shunt. Alveolar atelectasis and consolidation are not shown in the illustration. Vital signs: increased heart rate, systemic hypotension, decreased blood pressure, cyanosis, cough, and hemoptysis. Peripheral edema and neck vein distension may also be present, with distended neck veins, swollen and tender liver, ankle and feet swelling, and pitting edema. Chest pain and decreased chest expansion as well. Chest pain is frequently noted in patients with pulmonary emboli. The origin of the pain is obscure. It may be cardiac or pleuritic, but it is a common early finding in all forms of PE, even in the absence of clinically obvious cor pulmonale or pleuritic involvement. If the patient has hypotension, perfusion of the coronary arteries decreases, and classic angina like chest pain and ECG findings may be the result. Syncope, lightheadedness, and confusion may also occur. If the left ventricular output and systemic blood pressure decrease substantially, blood flow to the brain may also diminish. This may cause periods of lightheadedness, confusion, and even syncope. There may be abnormal heart tones, including increased second heart sound, S2, increased splitting of the second heart sound, S2, and third heart sound or ventricular gallop. We're going to talk a little bit about right ventricular heave. A right ventricular left can be detected if in patients with a pulmonary emboli if there is significant pulmonary hypertension present. If they have an elevated pulmonary blood pressure, right ventricular strain or right ventricular hypertrophy, or both, often develops, and when this occurs, a substantial outward lift of the chest wall can be felt at the lower left side of the sternum. By placing your hand on the sternum, it can be felt because the right ventricle lies directly beneath the sternum, as pictured here. Chest assessment findings. A common chest assessment finding when listening to the patient are crackles, wheezes, and often a pleuritic rub, especially when pulmonary infarction involves the pleura. Arterial blood gases can range from acute respiratory alkalosis with hypoxemia, in the severe stage, acute respiratory acidosis with severe hypoxemia. Oxygen that you may see and hemodynamic indices. Normally, the pulmonary artery pressure is no greater than 25/10 millimeters of mercury, with a mean pulmonary artery pressure of about 15 millimeters of mercury. Most patients with a pulmonary embolism, however, have a mean pulmonary artery pressure in excess of 20 millimeters of mercury. Three major mechanisms may contribute to this: decreased cross-sectional area of the pulmonary vascular system because of the embolism, vasoconstriction induced by humoral agents, and vasoconstriction-induced hypoxemia. The cross-sectional area of the pulmonary vascular system will decrease significantly if a large emboli becomes lodged in a major artery, or if a small emboli becomes large in numerous small pulmonary vessels. One of the consequences of pulmonary embolism is the release of certain humoral agents, primarily serotonin and prostaglandin. These agents induce muscle constriction of both the tracheobronchial tree and the pulmonary vascular system. Such smooth muscle constriction may further reduce the total cross-sectional area of the pulmonary vascular system and cause pulmonary artery pressure to rise. Abnormal electrocardiographic patterns. It's common to see sinus tachycardia, atrial arrhythmias, including atrial tachycardia, atrial flutter, and atrial fib. You may see acute right ventricular strain pattern and right block, and you may see a peaked P wave as well. In some cases, the obstruction of pulmonary blood flow produced by the pulmonary emboli leads to abnormal EKG patterns. However, there is no single EKG pattern diagnostic of pulmonary emboli. Abnormal patterns merely suggest that you have an irritated heart and the possibility of pulmonary embolic disease. Sinus tachycardia is the most common dysrhythmia seen. Sinus tachycardia and atrial arrhythmias, sometimes noted, are also thought to be related to the increased right-sided heart strain and cor pulmonale. In about 15 to 25% of patients, a quarter of all patients with a PE, the S1, Q3, and T3 pattern may be seen, which is a large S wave in the lead 1, plus a Q wave and an inverted T pattern in lead 3. Chest X-ray patterns. On a chest X-ray, it's possible to see increased density in infarcted areas, dead areas, hyperradiolucency distal to the emboli, dilation of the pulmonary arteries, pulmonary edema, right ventricular cardiomegaly or cor pulmonale, or pleural effusion, though it's usually small. This is what a pulmonary angiogram looks like. Please see the pulmonary emboli here. Pulmonary angiogram shows numerous filling defects. Trailing ends of the occluding thromboemboli are particularly well shown by the arrows. Fat emboli in a patient with dyspnea and hypoxemia after a recent orthopedic surgery. Perfusion, P, and ventilation, V. Radionuclide scans show multiple peripheral subsegmental perfusion deficits suggestive of fat emboli. These are VQ scans. the perfusion and the ventilation do not match. Pulmonary embolism infarction is a life-threatening condition. On admission to the hospital, immediate transfer to an intensive care unit is mandatory. The treatment of pulmonary embolism usually begins with treating the symptoms. Oxygen is administered per oxygen therapy protocol. The physician provides analgesics for pain and fluids and cardiovascular agents to correct blood pressure and cardiac dysrhythmias. Fast-acting anticoagulants such as heparin are given to prevent existing blood clots from growing any worse and to prevent the formation of new ones. Heparin is administered intravenously to achieve a rapid effect. High molecular weight heparin, unfractionated heparin, has until recently been the mainstay of treatment for patients with acute pulmonary embolism. However, monitoring and frequent dosing for this can be difficult. Recently, low molecular weight heparins have become available, such as enoxaparin, dalteparin, and tazoliprin, and have been shown to be safer and much more effective than the unfractionated heparin for prophylaxis of DVT and pulmonary emboli. They are also more cost-effective and don't necessitate monitoring. Doctors strive to achieve a full anticoagulant effect in the first 24 hours of treatment. This is typically followed by administration of a slow-acting oral anticoagulant such as Coumadin, warfarin, or something similar. Heparin and warfarin can be given together for 5 to 7 days or until blood tests show that the patient is effectively anticoagulated. Thrombolytic agents such as streptokinase, urokinase, alteplase, and reteplase actually dissolve clots. These are called clot busters. These systemic agents, commonly referred to as clot busters, have proven beneficial in treating active pulmonary embolism. They're sometimes used in conjunction with heparin, and their effect in patients with hemodynamic instability may be dramatic. Because of the excessive risk for bleeding, however, the use of these agents in treating pulmonary embolism is somewhat limited. Preventative measures like walking, exercise while seated, drinking fluids, wearing graduated compression stockings, using an inferior vena cava filter, a Greenfield filter, pneumatic compression, or pulmonary embolectomy have all been shown to be effective, safe, and simple. What will you do as a respiratory therapist? Maintain oxygen saturations using an oxygen therapy protocol. Use aerosolized medication to treat shortness of breath as needed. And use lung expansion therapy to prevent atelectasis. So let's talk about pulmonary hypertension. Pulmonary hypertension is an increase in mean pulmonary artery pressure greater than 25 millimeters of mercury. The pulmonary system, of course, is an area of low pressure. The normal range is 10 to 20 millimeters of mercury at rest. Pulmonary hypertension is a frequent complication of chronic pulmonary disease. It is more common among women than men at a ratio of about 3 to 1. The World Health Organization divides pulmonary hypertension into 5 different group classifications based on the cause and treatment options. Group 1 is pulmonary arterial hypertension, or PAH. Group 2, pulmonary hypertension because of left heart disease. Group 3 is pulmonary hypertension because of lung disease and or hypoxia. Group 4 is chronic thrombolytic pulmonary hypertension and other pulmonary artery obstructions. And then Group 5 is pulmonary hypertension with unclear and or multifactorial mechanisms. So pulmonary hypertension can be insidious. It can be really tough to diagnose, and patients can have mild to moderate PH for years with no remarkable signs or symptoms. A patient, it can take, some of the signs and symptoms are dyspnea, lightheadedness, fatigue, non-productive cough, hemoptysis, hoarseness, fainting or syncope, chest pain, a racing heartbeat, pain in the upper right side of the abdomen, lack of appetite, and peripheral edema. They can mimic a lot of other things. This shows an echocardiography in a pulmonary hypertension patient. In A, this is an apical 4-chamber view of the heart, revealing an enlarged right atrium and ventricle compressing the left cardiac chambers. A Doppler in echocardiography shows tricuspid insufficiency used to estimate the right ventricular systolic pressure. In this case, 107 millimeters of mercury. The left atrium, left ventricle, right atrium, and right ventricle are all shown and labeled. We're going to look at the difference. It's important for the respiratory therapist to be able to determine, because we see both right and left-sided heart failure patients, and left-sided heart failure for PAH is much more common. We want to differentiate between left-sided heart failure and right-sided heart failure, and also there's biventricular failure. So I'm going to talk a little bit about the signs and symptoms of both left-sided heart failure and right-sided heart failure. It's important for the respiratory therapist to distinguish both. In right-sided heart failure, you have shortness of breath, irregular fast heart rate, distended neck veins, peripheral edema and venous distension, distended neck veins, swollen and tender liver, ankle and feet swelling, pitting edema, heart palpitations, abdominal distension or bloating or ascites, abdominal pain, urinating more frequently at night, anorexia, nausea, fatigue, weakness and faintness, and weight gain. Left-sided heart failure, you have shortness of breath, common to both, lightheadedness and fainting, frothy blood-thin sputum, crackles, cough and hemoptysis, orthopnea, paroxysmal nocturnal dyspnea, weak pulse, hypotension, decreased urine production, activity intolerance, fatigue, weakness and faintness, weight gain and fluid retention, heart palpitations, anxiety, excessive sweating, cyanosis, and cool or clammy skin to the touch. That's left-sided heart failure, and these are much more common signs and symptoms. I want you to remember that PH has no cure. Symptoms may be progressive and slow to come on. Therapies to treat and manage pulmonary hypertension include diuretics to help decrease the fluid buildup, blood thinners to help prevent clots, digoxin to help the heart to pump stronger or control the rate. This is a picture of a right heart catheterization in pulmonary hypertension. In the left panel, a pulmonary artery catheter is observed in the left pulmonary artery. That's where the arrows are. In the right panel, the corresponding pulmonary artery pressure tracing is shown, confirming the diagnosis of pulmonary hypertension. In this case, the pulmonary artery systolic, diastolic, and mean pressure were 97 millimeters of mercury, 51 millimeters of mercury, and 68 millimeters of mercury. Therapies include treating oxygen therapy, treating hypoxemia, physical activity to improve exercise tolerance, inhaled nitric oxide, and to diminish pulmonary hypertension. The emerging role of the RT includes helping with inhaled gases such as ionoprost and treprostinil. Thank you for your time and attention. I want to leave you with one last thought from Mother Teresa, one of my favorite philosophers, that one person alone cannot change the world, but you can cast a stone across the waters to create many ripples. Thank you again, and have a great day.